Welcome, colleagues, to the third day of our first annual OncoAlert Colloquium. Along with our partners at MASC, CEOG, eCancer, and BJ Oncology, we bring you this first of its kind year in review of some of the biggest news in oncology for 2020, divided by tumor group. OncoAlert is an oncology network of medical, surgical, radiation oncologists, oncology nurses, cancer researchers, and most importantly, patient advocates who fight cancer through the spread of reliable scientific information regarding cancer and cancer treatments, fortifying the voice of our patients, and the promotion and creation of oncology education that is accessible to all. Our goal with this colloquium is to provide our colleagues with a reliable year in review by some of our OncoAlert faculty who are leaders in their field. This colloquium, like every OncoAlert initiative, is without sponsorship. Everything you will see during this week is possible because of the dedication of all of our OncoAlert faculty and friends who believe that as colleagues, we can make a difference in education globally, regardless of financial possibilities. As you have noticed, there is no signing up, there is no registration, and these videos will always be found on our YouTube channel, where the links can be shared, and we encourage you to do so. These presentations are the best of 2020. Today, we will discuss ovarian cancer, sarcomas, lymphomas, immunotherapies, targeted therapies, and liquid biopsies. Our presenters are Dizon of the Lifespan Cancer Institute presenting ovarian cancer, Dr. Jon Haanen of the Netherlands Cancer Institute presenting immunotherapies, Dr. Jon Trent from Sylvester Comprehensive Cancer Center presenting sarcomas, Dr. Raul Cordoba from the University Hospital Foundation Jimenez Diaz presenting lymphomas, Dr. Rolfo from the University of Maryland presenting liquid biopsies. We hope you enjoyed this colloquium, and we invite you to join us for day 5, where we'll be going through the best of 2020 in GU tumors, OncoAlert social media, and FDA approvals. Without further delay, Dr. Dizon.
It's my great honor to participate in the OncoAlert Colloquium. I've been asked to speak about ovarian cancer and give you some highlights from 2020. So these are my 5 highlights from this year. I'm going to update you on the role of surgery in recurrent platinum-sensitive disease. We'll talk about PARP inhibitors, both in the treatment of recurrent disease as well as some preliminary data really demonstrating that the activity of PARP inhibitors goes beyond people with ovarian cancer associated with mutations in BRCA. We'll talk about immunotherapy in ovarian cancer and how the search continues, but we're just not there yet. And finally, talking about people using PARP inhibitor as maintenance therapy, we'll talk about how we're following them while on treatment and what role CA-125 will play. My name is Dizon. I'm a professor of medicine at Brown University and director of the Breast and Pelvic Malignancies program at Lifespan Cancer Institute. So first, let's talk about surgery in recurrent ovarian cancer. This is being re-examined in light of 2 clinical trials that were presented at ASCO 2020. I will highlight the German AGO trial, which is here. It was a phase 3 trial looking at surgery versus no surgery in people with recurrent ovarian cancer. It was run by the German cooperative group and got. Here's the background that they had done a preliminary trial showing that there would be a predictive score that would predict the benefit from a secondary cytoreductive surgery. This AGO score consisted of performance status of 0, a complete resection at the first diagnosis, and then minimal ascites present at the time of recurrence. This score was then used in Desktop 3, which is the randomized trial. It included volunteers in first relapse with a platinum-sensitive recurrence score, all of whom met the AGO score criteria. They enrolled 408 patients, half of whom underwent cytoreductive surgery, and all patients were then treated with platinum-based chemotherapy. The patients are listed here. It was very well balanced. If you look at the surgical versus non-surgical group, the vast majority of these patients had prior platinum therapy and were platinum-free over 12 months. This is the main outcome in terms of overall survival. As you can see, compared to no surgery, the role or the use of surgery in the recurrent setting significantly improved overall survival by almost 8 months with a p-value of 0.02. And in terms of progression-free survival, there was a benefit of 4 months favoring surgery, again, a p-value of less than 0.001. Why is this relevant today, or why are we asking this question again? I will bring you to date. This was the American clinical trial, GOG 213, which looked at the same question, but in a dual study where volunteers were randomly assigned to surgery versus no surgery, and then were again randomly assigned to a chemotherapy treatment of carboplatin and paclitaxel with or without bevacizumab, which is important. Here are the results as presented by Dr. Robert Coleman, showing no statistically significant benefit to surgery in terms of overall survival, hazard ratio 1.28, and no statistically significant advantage in terms of progression-free survival. There was a third study that was presented at ASCO from the Chinese group, which is listed here on the right. As you can see, what Dr. Coleman did was compare these 3 trials in terms of eligibility criteria. The most important component of this was the role of bevacizumab in the second-line setting. Almost all patients in the American trial received it versus very minimal uses of bevacizumab in both the German and the Chinese studies. The main takeaways here to explain these differences were listed here by Dr. Coleman. The criteria was variable across studies. However, both the Chinese and the German studies used specific criteria to choose patients who enroll in this trial. And as a result, of better patient selection, perhaps, the results favored surgery. The impact of surgery was remarkably consistent, although statistical significance was not achieved in the American study. And finally, here probably explains the difference most notably, in my opinion, of why surgery was not statistically significantly advantageous in the American trial. The much higher use of bevacizumab likely contributed to the lack of statistical significance in GOG 213. But now we have 2 trials favoring surgical cytoreduction in selected patients with a platinum-sensitive recurrent ovarian cancer, and hence this is now a reasonable option for these patients. Moving on, let's talk about olaparib in recurrent ovarian cancer. And the highlight here was presented again at ASCO 2020. These were the final results of maintenance olaparib versus placebo in patients with a platinum-responsive relapsed ovarian cancer associated with a mutation in BRCA. To recall, this was the design of SOLO2. All volunteers had relapsed high-grade serous or endometrial cancer, a known mutation in BRCA, up to 2 prior lines of platinum-based chemotherapy with a response. It was a 2-to-1 randomization of olaparib versus placebo. And here, what was reported at ASCO was the overall survival analysis, which was planned once 60% of the data had matured. And here are the final results, the top-line results of SOLO2. There were 116 events and 65 in the placebo group. Remember, it was a 2-to-1 randomization, but median overall survival with placebo was 39 months, and with olaparib was 52 months. Statistically significant with a hazard ratio of 0.74. Of note, 38% of those patients on the placebo arm went on to receive subsequent PARP inhibitor therapy. The overall survival in the full analysis set was 0.70, with the upper limit of the hazard ratio at 0.96. And among those patients with a germline BRCA mutation based on a myriad analysis, consistent hazard ratio of 0.7, top line 0.97. So median overall survival improved by almost 13 months. This is despite 38% of the placebo patients receiving subsequent PARP inhibitor therapy, again, demonstrating the benefit of second-line platinum therapy followed by olaparib in these patients. What else was published in SOLO2 was right here. They did look at the incidence of myelodysplastic syndrome or acute myelogenous leukemia. And here what we're showing is that the mean total treatment duration in the final analysis was 29 months with olaparib, 13 months during the placebo. And what you're seeing is a notable increased incidence of MDS or AML in the olaparib arm. If you see here, they looked at these events that occurred during the follow-up period, and you had 4 events that occurred during follow-up, none here. With more follow-up time, you're still seeing an increased incidence here. So in patients with newly diagnosed ovarian cancer and a mutation in BRCA, this is not the study, but in SOLO1, there was 1%. Seemed to be the incidence in the frontline setting. Here we're seeing a much higher incidence of 8% versus 4%. Again, a signal that requires further clarification and definition, particularly because the majority of these events happen after the safety follow-up period. Going beyond that, there was other data looking at PARP inhibitors in the maintenance setting, asking the question, does it benefit people with mutations in homologous recombination repair outside of mutations in BRCA? This was an analysis using the ARIEL-3 data. It was presented at the Society for Gynecologic Oncology meeting in 2020. The volunteers here were people with platinum responsive recurrent ovarian cancer, randomly assigned to rucaparib at 600 milligrams twice a day versus placebo. And this was the exploratory evaluation of activity in volunteers with non-BRCA mutations in homologous recombination repair. Dr. O'Malley presented that 43 patients were found to have such mutations, and 28 of them were treated on the rucaparib arm, 15 received placebo. When you look compared to placebo, rucaparib was associated with an improvement in progression-free survival of about 6 months, and also was demonstrated a pretty prolonged chemotherapy-free interval of 18 months versus 7.7. Far from conclusive, hypothesis generating, but supports the notion that maintenance PARP inhibitors may play a role in people with mutations in homologous recombination repair outside of the mutations in BRCA. The fourth one we'll talk about is immunotherapy in ovarian cancer. This was presented at the ESMO meeting in 2020 by Dr. Kathleen Moore, and demonstrates for me how much we still need to learn and understand as it relates to the role of immunotherapy in ovarian cancer. This is the Imagine-050 study. It took patients at their first diagnosis with either stage 3, stage 4, or unresectable disease. They could have had neoadjuvant therapy, and they were randomly assigned 1-to-1 to chemotherapy plus bevacizumab and either placebo or the PD-L1 inhibitor atezolizumab. There was no crossover design in this study. And as presented at ESMO, in the intention to treat analysis, compared to placebo, atezolizumab did not improve progression-free survival. There was no difference. It was 19.5 versus 18.4 months with placebo, hazard ratio of 0.92. And when you look at people who had PD-L1 positive tumors, there was still no difference in progression-free survival, 20.8 versus 18.5 months, hazard ratio of 0.8. Now, if you looked at a subgroup analysis, this is hypothesis generating, for patients who are strongly PD-L1 positive at 5% or greater staining, there was a potential benefit seen with atezolizumab, where progression-free survival median was not reached versus in the placebo arm where it's 20.2 months. And here the hazard ratio was 0.64, upper limit at 0.96. So overall, the analysis is negative. It does not support the role of atezolizumab in combination with chemotherapy and bevacizumab in advanced or unresectable ovarian cancer. Finally, let's talk about a study that looked at the role of CA-125 monitoring in people who are taking PARP inhibitors following chemotherapy or what is called maintenance treatment. This is a really relevant question because we are now in an era where PARP inhibitors have become a mainstay of treatment in both the frontline setting based on the SOLO-1 clinical trial, the PRIMA clinical trial of niraparib, and even the PAOLA-1 trial where olaparib is combined with bevacizumab. All three trials showing a frontline maintenance advantage in prolonging PFS for people with newly diagnosed ovarian cancer, as well as in the recurrent platinum responsive setting where we have data on rucaparib, we have data on olaparib, and we have data on niraparib, the three PARP inhibitors that have been approved for use in the United States by the Food and Drug Administration. The question that was proposed in this very, very nice poster presented at ASCO 2020 asked the question of how do we monitor these patients and can we rely on CA-125? This study utilized volunteer data from the SOLO-2 clinical trial, which I presented earlier, which showed an overall survival advantage to maintenance olaparib among people with a BRCA mutation associated ovarian cancer who had relapsed with platinum responsive ovarian cancer. What they ask is, can you monitor based on CA-125 and how does that differ or is it concordant with imaging-based definitions of progression based on what's called RECIST criteria. So here in the first first table, they use defined CA-125 criteria to characterize volunteers as either having progressed or having non-progressive disease. Now, if you look at those patients who had progressed based on imaging, there was a concordance of about 96% where the CA-125 matched imaging. And in terms of using that CA-125 progression to call it, very few patients did not show imaging-defined progressive disease. However, if you look at the proportion of patients who had a CA-125 that did not meet criteria for progression, 48% of the time they had progressed by imaging. 52% of the time there was concordance, no progression by CA-125, no progression by imaging. So this number is very striking that a non-progression based on CA-125, almost half the time you'll see progression by imaging, but progression by CA-125 is correlated with progression on imaging. Now here you're seeing RECIST-defined progression based on olaparib versus placebo, again on SOLO-2. And CA-125 progressive disease on olaparib, very good correlation with imaging. So imaging defined progressive disease, correlates with CA-125. However, not seeing progression by CA-125, 40% of the time you're going to see progression on imaging on olaparib, and only 60% of the time you're going to see concordance. So what does this tell us? It tells us you can use CA-125, and rising CA-125 predicts well or correlates well with what you will see on imaging. So this is very good. It's a very good marker of disease progression on olaparib. However, normal or non-progressive values in CA-125, we cannot rely on that, because what we are seeing is about 4 out of 10 times you see non-progression in the CA-125, you're going to pick up progression by imaging. This tells us then surveillance imaging is important for our patients on maintenance PARP inhibitors, and that we cannot solely rely on normal or non-progressive CA-125 to ensure patients are still benefiting on this kind of therapy. So in conclusion, PARP inhibitors have an established role in the treatment of ovarian cancer. These are expanding beyond just mutations in BRCA, and it's expanding from the frontline setting to the platinum responsive recurrent setting. We need to understand the risks of therapy and also how to appropriately manage our patients who are on these inhibitors. We now know that surgery remains a crucial tool in the relapse setting of ovarian cancer, and these data are all coming through clinical trials, stressing the point that clinical trials remain critical in our quest to improve the lives of people with ovarian cancer. With that, I want to give my thanks to the OncoAlert Colloquium and also to my friend Gil Morgan for giving me the opportunity to present these data. Thank you very, very much.
Hi, my name is Jon Haanen. I'm a medical oncologist working at the Netherlands Cancer Institute in Amsterdam. I would like to discuss today the highlights of immunotherapy in 2020. Here are my disclosures. I would like to touch upon novel concepts and important progress made over this year. Important progress in moving immunotherapies to earlier stages over a growing list of cancer types, but also the success of neoadjuvant immunotherapy, advances in cell therapy, and the COVID-19 pandemic and patients that are treated with immunotherapy. In novel concepts, the role of B cells, targeting novel immune checkpoint, and targeting metabolic pathways as new ways of improving immunotherapy. When we look at a large list of different cancer types, we have seen that, for instance, for melanoma, lung cancer, kidney cancer, immunotherapy has become first line of treatment. In a growing number of cancer types, we can see that from late stage to earlier stage, to earlier lines, immunotherapies are moving as well. And in leukemia, lymphoma, and multiple myeloma, we see that the arrival of CAR T-cell therapy leads to indeed improvement in survival of these patients. One other way of improving immunotherapy is by giving it even in much earlier stage, like stage 2 or stage 3 disease, where we first perform surgery on the primary tumor and then treat patients with immunotherapy in the adjuvant situation. And we know that this concept works because we see an improvement in relapse-free survival with adjuvant anti-PD-1 treatment in stage 3 and melanoma. Here you see the 4-year and 3.5-year updated relapse-free survival of the CheckMate 238 and Keynote 54 study. Both nivolumab and pembrolizumab, compared to their control arm, improve also over time the relapse-free survival. In general, we could say that anti-PD-1 treatment in stage 3 melanoma improves relapse-free survival by about 20%. This year at ESMO 2020, we saw the results of the CheckMate 577 study. There, patients with esophageal cancer were treated with standard of care for the primary disease, followed by adjuvant nivolumab versus placebo. You can see that by adjuvant nivolumab treatment, the disease-free survival improved from 11 months to 22.4 months. A really amazing improvement. Of course, this has to be translated to an overall survival difference as well. What if we would give the adjuvant treatment prior to surgery? The concept of giving the treatment before the surgery has the advantage that the primary tumor is still present. Why is that important? When the primary tumor is still present, the immunotherapy can lead to reinvigoration of the inhibited T cells in the tumor environment and perhaps even induce a broader T cell response to the tumor. In addition, the circulating tumor-specific T cells could eradicate micrometastatic distant disease. And in the end, hopefully memory formation will be formed to prevent recurrence of the cancer. Here are some examples that also this concept seems to work very efficiently. These are the results of the OPECIN-NEO trial, where 2 courses of ipilimumab plus nivolumab were given to patients with stage 3B/C melanoma prior to surgery. Those patients that had a pathologic response, either partial, near, complete, or complete, had an excellent relapse-free survival with 18 months of follow-up. Patients with no pathologic response did much poorly. When we look at the number of patients that responded, the majority of patients, so 70%, had one of those pathologic response rates. But not only in melanoma, also here in stage 2-3 colorectal cancer, 2 courses of neoadjuvant immunotherapy resulted in high pathologic response rates, both in the MSI high tumors, where we probably would expect a response occurring because stage 4 disease is highly sensitive to immunotherapy, but also in MSS tumors, where stage 4 disease is hardly any response to immunotherapy. In this graph, you see the hematopathological tumor regressions in red of the MSI high tumors, and almost all tumors had a major pathological response. One had only 80% tumor reduction. In the MSS tumors, we see that 25% of patients had a major pathologic response, which is really amazing. And we have to wait for the maturing of the data in order to see the relapse-free survival as well. In patients with muscle-invasive bladder cancer, neoadjuvant immunotherapy also results in a high pathological response rate. And you can see that this translates into a very impressive relapse-free and overall survival. These data, again, have to mature over time to see how these data will perform later on. And in patients with head and neck cancer that require large surgeries, mutilating surgeries, neoadjuvant immunotherapy again led to about 33% high pathologic response rate. And when you look at those patients here in green that had a major pathologic response, and you look at the relapse-free survival, these patients do extremely well, even over 3 years at that time. So I think there's a bright future for neoadjuvant immunotherapy, and we need to explore whom these patients are that do respond. If we now put together adjuvant versus neoadjuvant immunotherapy, we can say that in the adjuvant situation, especially in the pivotal trials, patients were selected not to have progressed before start of adjuvant treatment. 15% already had progressed and did not participate in the adjuvant treatment. The duration is 1 year, which is not based on any biological evidence. Treatment usually consists of single agent anti-PD-1 or anti-PD-L1. Response evaluation is not possible. There's only very few options for translational research. It's expensive because of duration and in general well tolerated. In the neoadjuvant patient population, in fact, all patients can be treated unless there is a clear contraindication for IO treatment. The duration of the treatment is short-lived. Of course, there's a risk of tumors becoming unresectable that needs to be kept in mind. Combinations can be easily tested because of the short duration. there's more chance of inducing a systemic immune response based on preclinical data. Evaluation is feasible. Non-responders could even be counseled for alternative adjuvant treatment, and lots of options for translational biomarker research are there. The chance for higher toxicity, especially in combination, is certainly a case, and it's much cheaper. I think immunotherapy, neoadjuvant immunotherapy is the way to go forward. What about advances in cell therapy? In 2020, compared to last year, we see that there are more studies ongoing with CAR T cell therapy, but also in the other platforms like NK cell therapy, TCR T cell therapy, TIL therapy, there are more trials ongoing. And when we look at the different targets, you can see that the majority of study is still targeting CD19, also in 2020, and BCMA in hematologic malignancies, but you can see there is more activity in CD20, CD22, and novel targets. In the solid cancers, the majority is still directed at tumor-associated antigens, but then there's a large list of other antigens that are being tested as well, and hopefully one of those or a few of those will become a breakthrough. Over time, the number of clinical trials with cell therapy is rapidly growing. In not only hematologic malignancies, but also in solid cancers. And when we look at where these trials are being taking place, in yellow for pharma-driven studies and blue for academically performed studies, you can see that the majority of trials in 2020 are ongoing in the United States and in China, and Europe is a little bit lagging behind. But hopefully, within a couple of years, we see that cell therapy is become another standard of care. Then last, COVID-19 and immunotherapy. When we look at the WHO report of November 21, 2020 on the COVID-19 pandemic, we see that there is still an increase in the number of confirmed cases. We are now at almost 57 million people, with 1.36 million people died from COVID-19. Especially in cancer patients, we have to worry because there is some interplay between the virus and cancer biology. We know that SARS-CoV-2 for internalization requires ACE receptor and TMPRSS2 expression. ACE expression is driven, for instance, by smoking, but also by age, whereas the TMPRSS2 expression is perhaps driven by androgens. We know that a lot of cancer patients have disease that was driven by smoking, and a lot of cancer patients are still smoking, and usually also have an elderly age. We know that severe COVID-19 may be the case of disruption of natural barriers. Cancer patients often have that, because, for instance, the use of chemotherapy. Cancer itself can lead to an immune suppressive state, and sometimes also by giving certain treatments, we induce immunosuppression. In cancer patients, activation of an innate immune system may be present, which may even lead to a more severe cytokine storm, as is seen in COVID-19. Also, ICI treatment and CAR T cell therapy may lead to a more severe cytokine storm. On the level of arterial and venous thrombotic events that have been seen as in patients with a severe COVID-19, we know that cancer patients have already a baseline proagulant state, and therefore may have more chance of developing these severe symptoms. When we look at this large table of studies that have been evaluating clinical factors associated with adverse prognosis in patients with cancer who develop COVID-19, these are all retrospective registry studies rapidly designed in the different countries, in different continents, and globally, which have taught us a lot about how patients with cancer fare. At the start of this pandemic, we were all afraid of giving patients immune checkpoint blockade because we were afraid they would have a severe course of COVID-19. Drugs were interrupted, drugs were postponed, or patients were not even treated. These registries have been extremely important in getting more information about whether that was justified or not. What we have learned is that patients with lung cancer, and especially hematological cancers, have the highest risk of developing a severe course of COVID-19. Also, patients with progressive cancers compared to patients that are remission or with metastatic disease compared to patients with early disease have a more higher risk of developing COVID-19. Patients treated with chemotherapy, especially hematologic patients, but also other cancer patients, may have a worse outcome of COVID-19. But for immune checkpoint blockade, the jury is still a little bit out. I think the majority of studies direct towards not a major effect of immune checkpoint blockade, not in a negative way or in a positive way. I think it's safe to treat patients now with immune checkpoint blockade when they really require it. So the only thing we can hope for is that once the SARS-CoV-2 vaccines become available, that cancer patients will be on the front row and will be treated, and hopefully they will mount an effective immunity against the virus, and therefore do not have to worry anymore about their treatment. Now, going back to novel concepts, over the years, we have mostly targeted T cells in order to activate them to fight the cancer. B cells have a little bit of a bad name because the presence of B cells in the tumor environment was often associated with poor outcome. Now in 2020, 3 Nature articles were published showing that B cells in the tumor environment are associated with a better outcome to immunotherapy in sarcoma, in melanoma and kidney cancer, and again in melanoma. And also the tertiary lymphoid structures are being involved in here. What are tertiary lymphoid structures? These are small areas within the tumor environment that consist of germinal centers and T cell zones, resembling therefore small lymph nodes. And in these TLSs, we see not only B cells and CD4 T cells and memory T cells, CD8 T cells, but we also see mature dendritic cells and follicular helper dendritic cells that present antigens to T cells and B cells. And one of the driving roles for the influx of B cells in the tumor environment, but also TLS formation, is CXCL13, a chemokine coming from dendritic cells or follicular helper cells, but also highly expressing PD-1 expressing CD8 T cells in the tumor environment. And we think that these tertiary lymphoid structures are important for antigen presentation, so tumor antigen presentation, and therefore mounting an immune response against the tumor, which can be even invigorated by the immune checkpoint blockade. And whether the B cells and the antibodies that are being produced have an anti-cancer effect or not is still something that we have to learn. We know also that type 1 interferon induces CXCL13, and type 1 interferon is often generated within the tumor environment, and that the expression of CXCL13 is associated with a better outcome to immune checkpoint blockade, in this case in metastatic bladder cancer. So here you see patients that were treated either in the Checkmate 275 or IMvigor 210 study, 2 large studies in bladder cancer, showing that those patients having a high CXCL13 expression had a much better survival compared to patients that did have an intermediate or low expression. What about targeting novel immune checkpoints? When a couple of years ago we were asked to write a review about how we saw the future of immunotherapies, Ignacio Melero and I realized that PD-1 and PD-L1 should be a backbone that could be combined with many other therapies, either co-stimulatory targeting antibodies or antibodies targeting other checkpoints or cell therapies. And currently there are many trials, over 2,800 trials ongoing with combinatorial immunotherapy. And they are targeting over 300 different molecules. But important to realize is that many of these combination trials are not based on biological mechanisms and are therefore likely to fail. But one molecule that is probably not going to fail is TIGIT, which is a T-cell immunoreceptor and immunoglobulin and item domains. It's an inhibitory molecule, so an immune checkpoint that expressed by activated T cells and NK cells. And upon expression of this TIGIT molecule, it can bind to the poliovirus receptor, or CD155, which is often expressed on tumor cells and antigen-presenting cells, and thereby inhibits the function of the T cell. TIGIT expression is linked to PD-1 expression until, and like I said, many tumor types under DC express the poliovirus receptor at CD155. Tiragolumab is one of those antibodies that can block the binding of TIGIT to its receptor. In preclinical models, the combination of PD-L1 and TIGIT blockade had clearly synergistic effect in tumor control. The CITYSCAPE study was presented at ASCO this year. It's a first-line phase 2 study in non-small cell lung cancer patients with tumors that had PD-L1 expression of 1% or higher. 135 patients were randomized 1-to-1 between tiragolumab plus atezolizumab versus placebo plus atezolizumab. The co-primary endpoint was objective response rate and PFS. And what you can see in the intention to treat analysis is that for objective response rate, the combination of tiragolumab and atezolizumab had a higher response rate. But this was completely driven by patients having a high PD-L1 expressing tumor of 50% and higher. This was also the case for PFS. So patients that have a PD-L1, a TPS score of 50% or of higher are likely to benefit more from the combination of anti-TIGIT and an anti-PD-1, PD-L1 drug than anti-PD-1 drug alone. And of course, this needs to be further proven in a phase 3 randomized controlled trial, which is started. Now, the last is targeting metabolic pathways in the tumor environment, another important new concept. When we look at tumors, there often is a lot of tumor cell death and also hypoxia occurring. And during this tumor cell death, ATP can be released. It depends a little bit on how these tumor cells die. But when ATP is released, ATP is a danger-associated molecular pathogen molecule and can activate the immune system. It can be degraded to AMP and adenosine by two ectonucleotidases molecules that are expressed at the cell surface of tumor cells or other cells in the tumor environment, like CD37 and CD73. Once adenosine is being formed, adenosine can bind to different adenosine receptors, the most important one here being the A2A receptor, which is expressed on CD8 T cells and CD4 T cells, and also regulatory T cells. In the CD8 and CD4 T cells, expression and binding of adenosine to the A2A receptor leads to an inhibition of the cellular functions like cytokine release and cellular ligand activity. There are already several drugs being tested, either antibodies targeting CD73 or small molecules targeting the A2A receptor. There are also molecules developed against anti-CD39, but they're still not yet in clinical trial. And of course, we hope that by combining these new drugs together with immune checkpoint blockade, immune responses and cancer therapies will be further improved. Here's an example of that was recently published of expression of CD73 in patients with renal cell cancer. Expression of CD73 was especially high in tumors with high-grade tumors and sarcomatoid renal cell cancers. When we look at the outcome of patients that have a high expression, we can see that the outcome of these patients is much poorer compared to patients with low or negative CD73 expression. And again, targeting CD73, for instance, combining it with immune checkpoint blockade may be very important for this particular type of cancer. And with that, I've come to the end of my presentation and would like to thank you very much.
Greetings. This is Dr. Jonathan Trent from Sylvester Comprehensive Cancer Center at the University of Miami. I will be presenting the sarcoma section in the OncoAlert Colloquium 2020 on new agents approved for gastrointestinal stromal tumor and exciting new agents for patients with this disease. If you have any questions, feel free to reach out to me by email or by question on Twitter. Gastrointestinal stromal tumor is rare, but it's 80% of GI sarcomas, high frequency of metastatic disease, and the gene mutation drives the phenotype of the tumor and therapeutic selection. Metastatic disease is treated with tyrosine kinase inhibitors, where patients with imatinib have a progression-free survival of 24 months. Patients treated with sunitinib have a PFS of 6 months on median, and patients treated with regorafenib may have a PFS of 5 months on median. Several new agents came on board recently, including ripretinib, which provides a PFS of 6.3 months, and avapritinib provides a PFS of 3.7 months. Of note, when patients with a PDGFR alpha mutant GIST are treated with imatinib, the median PFS has not been reached yet and is exceeding 20 months. There are now known molecular subtypes of GIST. KIT exon 11 and KIT exon 9 are the most common. In these situations, there can be resistance mutations in KIT exon 13 at the ATP binding site and exon 17 in the A loop that prevent imatinib from inhibiting this kinase. Other types of GIST include PDGFR mutated, SDH deficient, RAF mutated, NF1, RAS, PI3 kinase, IGF-1R expressing, and more recently, TRK fusion GIST. This is important because the genotype drives the treatment. As you can see on this slide, we pair up the optimal treatment with the type of mutation the patient has in their GI stromal tumor that is the driver mutation. Unfortunately, in the United States, we recently searched the National Cancer Database and found that only approximately 30% of GIST patients are undergoing mutation testing to understand what type of mutation is driving their tumor. In other words, 70% of metastatic GIST patients are not having access to mutation testing and are being treated blindly with drugs that would have an unknown activity since they're not being paired with the mutation. At Sylvester Comprehensive Cancer Center, all progressive GIST patients are undergoing circulating tumor DNA testing so that we can identify not only the driver mutation, but the resistance mutation. In our recent study that we published this year in JCO Precision Oncology, we found that most of these mutations do in fact occur in KIT exon 11, KIT exon 9, and PDGF receptor, with other sites noted as well, as you saw on the previous slide. Of importance, almost 60% of patients who become resistant to imatinib have KIT exon 17 mutations, while as about a third have mutations in KIT exon 13 in terms of resistance mutations. This will become increasingly important, as you'll see. On this slide, we have a heat map. And in this heat map, green shows activity of a kinase inhibitor against a kinase. Red shows resistance of a kinase inhibitor against a kinase. And you'll see on the far left column various tyrosine kinase inhibitors that are FDA approved or in study for FDA approval. And then across the top row, you'll notice primary mutations and resistance mutations. All of these kinase inhibitors on the left have potent activity against the primary mutations at exon 9 and exon 11. However, resistance mutations show some heterogeneity. For instance, you'll notice that sunitinib is a potent inhibitor at exon 13 and 14, but limited activity at exon 17 and 18. Whereas the majority of these other tyrosine kinase inhibitors, such as regorafenib, PLX 9486, avapritinib, ripretinib. These have activity against exon 17 and 18 in this heat map shows, but more limited activity against exon 13. So now we're seeing divergent activity against resistant mutations. So that sets the stage for some of the newer studies. In the Invictus study, patients were randomized in a 2-to-1 fashion for ripretinib versus placebo at 150 milligrams per day. And the stratification included patients who had 3 or greater than or equal to 4 lines of therapy, ECOG performance status, etc. Patients were followed until disease progression. If they were on ripretinib, they could undergo dose escalation to 150 milligrams twice a day. If they were randomized to placebo, they could cross over to ripretinib and be again followed until disease progression. This, the randomization was fairly equal in terms of patient demographics and tumor characteristics, and fairly representative of the GIST patients that we see in clinic. Of note, ripretinib significantly improved the median progression-free survival versus placebo. As you can see in this Kaplan-Meier analysis of progression-free survival, the purple curve had a median PFS of 6.3 months compared to the median PFS of placebo, which was only 1 month as represented in the gray curve. 9% of patients had a confirmed objective response on ripretinib. All of these partial responses. A substantial number of patients had stable disease at 6 weeks and 12 weeks on ripretinib. On the other hand, patients randomized to placebo did not respond and had fairly rapid progression within the 12-week period of 95% of patients. Now, importantly, those patients who did respond, the partial responding patients to ripretinib, have a duration of response that hasn't even been reached yet on median. So that seems to be durable in this subset of patients. Overall survival was also significantly different to favor ripretinib, as shown in the purple curve of 15.1 months on median versus 6.6 months for placebo. This ripretinib was very well tolerated, with 5% or less of patients have any grade 3 or grade 4 toxicity. So this is a very well tolerated drug. Of note, the most common toxicity is alopecia, so it's important to mention this to your patients as well. Thus, the Invictus study showed that ripretinib is effective as 4th-line or greater than 4th-line therapy for patients with advanced GIST with a median PFS of 6.3 months and a 9% objective response rate. Of note, patients who did respond had durable responses with a median not even reached yet. Another new agent has been studied this year and FDA approved for our GIST patients in the Navigator study, which is an open label dose escalation and dose expansion phase 1 study of avapritinib. Patients had to have at least 2 prior lines of TKI, had to have a mutation in KIT or PDGF receptor. These patients received avapritinib, PO daily, up to the recommended phase 2 dose. In the pivotal analysis, 2 subsets were studied: 4th-line and greater GIST of 121 patients, and PDGF receptor alpha exon 18 GIST 43 patients, with key objectives of response rate, duration of response, and safety. And again, this subset of patients that were treated on this study are fairly representative of our GIST patients in terms of age, race, ethnicity, mutation type, as well as prior TKI therapies. On the Navigator study, you'll note again that grade 3 and greater toxicity was fairly rare, with the exception of fatigue and anemia. Grade 3 anemia is represented here at 58% of patients. So it is reported, 58 patients total, 28% of patients. So it is reported with this agent. Other side effects, including diarrhea, decreased appetite, fatigue, are less common than the anemia. Now let's talk activity. When avapritinib was given to patients with PDGF receptor alpha exon 18 mutation, it was found to be exceptionally effective. When you look at this waterfall plot, you can see the very large number of patients who had tumor regression. And in fact, only 2 patients out of the 43 had tumor growth in this study. And again, these are patients with PDGF receptor alpha, most of them D842V mutation, what is resistance to all other known TKIs. This resulted in 86% objective response rate, so a very high response rate. There were CRs observed as well. On the other hand, 4th line plus KIT mutated GIST patients treated with avapritinib also showed responses. The objective response rate was 22%. So 22% of patients did have regression. However, the complete response rate was less, and there were more patients who progressed than when avapritinib is administered to a patient with PDGFR D842V mutation. Of those patients who did respond, the duration of response exceeded 10 months. So also durable therapy in this population of heavily pretreated GIST patients, 4th line and plus therapy, who achieved a 10-month response. In conclusion, the Navigator study provided data of activity of avapritinib against PDGFR exon 18 mutated GIST, but also activity in the 4th line for GIST patients who were heavily pretreated and had minimally other treatment options. Now we're going to talk about a new study, and this is a study looking at PLX 9486. In the phase 1 study that was presented at ASCO 2018, we found the recommended phase 2 dose. It was also combined with pexidartinib. And then there was a dose expansion for in part 2E, where 18 patients were treated with the combination of PLX 9486 plus sunitinib. Why is this combination important? Well, it's important because PLX 9486, as you remember, is a very potent inhibitor of KIT exon 11 and 9 mutations, and also a potent inhibitor of exon 17 resistance mutations, but not exon 13. On the other hand, sunitinib is a potent inhibitor against KIT exon 11 and 9 mutations, but also a potent inhibitor against KIT exon 13 resistance mutations, but not exon 17 mutations. So they're complementary in their ability to target resistance mutations in imatinib-resistant GIST patients. They're also complementary in their ability to bind KIT in the active conformation as well as the inactive conformation in the combination. In this expansion study, we looked at 3 different dose levels, including dose level 3, which is the full recommended phase 2 dose of both agents. And you'll see that this population is heavily pretreated. Of note, particularly in dose level 3, there was a median of 4 prior regimens, and 80% of the patients had 3 or greater lines of therapy. Everybody had had imatinib. Most patients had had sunitinib and regorafenib previously. Now we're going to look at the Kaplan-Meier analysis for progression-free survival. And you'll note on the far left, the first curve represents low-dose PLX 9486 with a median PFS that's relatively short. And you'll notice that the median PFS of about 2 to 3 months, the median PFS of recommended phase 2 dose of PLX 9486 is approximately 6 months. The addition of sunitinib to PLX 9486 doubled the median progression-free survival to 12 months. Now I'm going to show you some examples of the importance of precision medicine in our GIST patients. This is a 55-year-old man with gastric GIST who had a KIT exon 11 mutation. He was treated with multiple lines of therapy, developed an exon 17 resistance mutation. This was a few years ago, so we chose ponatinib for its potent activity at exon 17, and the patient had a durable response with ponatinib, which targets KIT exon 17 resistant mutations. Now I'm going to share another case of a patient that we've published, and in this patient with KIT exon 11 mutation develops a KIT exon 13 mutation, and although they had been on other prior therapies, we chose sunitinib because of its potent activity against KIT exon 13 and saw a spectacular response in a very highly aggressive progressive tumor. So in conclusion, primary and resistant mutations should be determined in order to provide optimal therapy for GIST patients. Liquid biopsy, ctDNA, is a rapid, non-invasive tool to detect these primary and resistance mutations. Avapritinib and ripretinib are new active agents for GIST patients. Newer approaches, such as combination therapy with complementary agents, such as PLX9486 and sunitinib, are on the horizon. Now, we also have to ask what are the roles of these agents in earlier lines of therapy, in neoadjuvant, adjuvant therapy, in combinations, as mentioned. I'd like to thank the GIST and sarcoma team at Sylvester for the excellent care that they provide to our patients and clinical trials. And I'd like to thank the patients that participate in these clinical trials, as well as thanking you, the audience, for taking time out of your busy schedule to participate in our OncoAlert Colloquium 2020. Thank you very much, and feel free to reach out to me by email or Twitter. Have a great day.
Hello, everyone. My name is Raul Cordoba. I am the head of the lymphoma unit at Fundación Jimenez Diaz University Hospital in Madrid, Spain. And it's for me a great honor and pleasure to join to this OncoAlert Colloquium in order to review with you the biggest news in 2020 for lymphoma patients. This is going to be the agenda of my talk. First of all, I want to start with the impact of COVID-19 pandemic in patients with lymphoma. Then I want to highlight the published of 2 new guidelines or updates in non-Hodgkin lymphoma. Then I'm going to review with you the new FDA approvals that has occurred in this 2020. And finally, I want to focus in vulnerable populations and specifically in older adults with lymphoma. What about the impact of COVID-19 pandemic in patients with lymphoma? As you know, the COVID-19 cumulative cases worldwide has not hit in the same way in the different regions in the world. And in the last update of the Johns Hopkins University, the hardest hit regions in the world have been Europe and North America. And if we check the 3 hardest hit countries with the global cases and global deaths, these 3 countries have been the United States, India, and Brazil. And in case of global cases by country, Europe has been very hard hit. And in case of Spain, we are in the 8th position of this rank. Regarding this aspect, the hematology community has made a great effort in order to collect all data in order to check for the outcome for patients with hematological malignancies and COVID-19 infection. The American Society of Hematology launched a research collaborative data hub and published very recently the preliminary report of the first 250 patients with a mortality rate of almost 30% of patients. And in this first and preliminary report, 43% of these patients had the diagnosis of lymphoma. And if you can see in the right-hand side of the slide, 42% of mortality was observed among patients with moderate or severe COVID-19 infection. What about what happened in Spain? We conducted a population-based registry study in Madrid, which was the hardest hit city in Spain, and we collected almost 700 patients with hematological malignancies, and almost 70% of them had the diagnosis of lymphoid malignancy, including patients with non-Hodgkin lymphoma, chronic lymphocytic leukemia, and also multiple myeloma. And the fatality rate in our population-based registry study was again over 30% of our cases. And we identified clinically relevant variables that were associated with increased mortality rate, and these variables were increasing age over 60 years old, having 2 or more comorbidities, the diagnosis of acute myeloid leukemia in comparison with non-Hodgkin lymphoma, and active antineoplastic treatment. And in case of non-Hodgkin lymphoma, the active treatment with monoclonal antibody. Then we knew that patients with this therapy were not able to develop an humoral response with a production of immunoglobulins against COVID-19 infection. But in 2020, there has been more topics beyond COVID-19 infection, and the European Society of Medical Oncology, the ESMO, has published 2 new guidelines for the diagnosis and treatment of 2 different subtypes of non-Hodgkin lymphoma. The first one I want to highlight is the marginal zone lymphoma ESMO guidelines, and they have reviewed the distinct disease entities, and the authors have discussed them separately, and they have a special focused in extranodal marginal zone lymphoma, MALT lymphomas. And the second guideline just recently published was the newly diagnosed and relapsed follicular lymphoma ESMO guidelines. And in this case, the authors has made an update in the localized stage treatment with the recommendation of combination of radiation and rituximab monotherapy that may be considered, because we now know that patients with localized stage receiving only rituximab have an increase in the relapse rate outside the radiation field. In advanced stage, either obinutuzumab or rituximab may be combined with chemotherapy. In early relapses, a switch of chemotherapy and also a monoclonal antibody is recommended, and in younger patients, the intensification with autologous stem cell transplantation should be discussed, at least in patients in the subgroup of POD24, which is the patients in the progression of disease in the within the first 2 years of diagnosis. And finally, in older patients with either early, first, or later relapses, the combination of lenalidomide plus rituximab, which is a chemo-free regimen, may be considered. What drugs have been approved by the FDA in 2020? I'm going to present you the 3 drugs approved in 3 different lymphoma subtypes. The first one is tazemetostat, which is an methyltransferase inhibitor that has been approved for follicular lymphoma patients, but also for epithelioid sarcoma. In the case of follicular lymphoma, it has been approved for adult patients with relapsed or refractory follicular lymphoma with a mutation in EZH2 mutation that has to be demonstrated by an FDA-approved test. And these patients should not have more satisfactory alternative treatment options. The second drug approved by the FDA is in another lymphoma subtype, in this case in mantle cell lymphoma, and it's a live drug. It's another CAR T cell, in this case rexucaftagen autoleucel, which is another CD19 directed genetically modified autologous T-cell immunotherapy, indicated in this case only for the treatment of adult patients with relapsed or refractory mantle cell lymphoma. And the third drug approved has been tafasitamab, which is a CD19 monoclonal antibody in combination with lenalidomide for the treatment of adult patients with relapsed and or refractory diffuse large B-cell lymphoma. So 3 new approvals for 3 different non-Hodgkin lymphoma entities. And finally, I want to focus in vulnerable populations. OncoAlert has reached an agreement of collaboration with SIOC, the International Society of Geriatric Oncology, and I'm going to focus in the recent updates and publications about all the adults with lymphoma. The first paper I want to discuss is this one about the age-dependent increase of treatment-related mortality in older patients with aggressive B-cell non-Hodgkin lymphoma. The aim of geriatric hematology is to identify which patients are robust enough to be treated with the standard therapy in order not to be undertreated, but also in order to, the aim is to identify which patients are frail in order not to be overtreated and not to give them toxicity. And regarding this topic, we have seen in this paper analyzing the outcome of all the patients in 2 different clinical trials coming from the German lymphoma study group with over 1,000 older patients with aggressive lymphoma. And you see that patients over 76 years of age, they are going to have an increase in treatment-related mortality. So the future is to identify which patients are going to be robust enough to be treated with these regimens and those that are frail in order to receive an attenuated or tailored therapy. The second study that I want to highlight in this discussion is the clinical outcomes in more than 2,000 patients with more than 85 years of age, so very old lymphoma patients coming from the Nordic lymphoma study group. And as you can see, there is an encouraging relative survival improvement in very old patients with several subtypes of non-Hodgkin lymphoma. And active treatment improves this relative survival for all patients with aggressive lymphomas and in diffuse large B-cell lymphoma in particular. And we have learned from this study that patients with indolent lymphomas, treatment was not associated with a reduced excess of mortality, and therefore we should offer only therapy when these patients are symptomatic. The third study that I want to highlight is this one coming from the UK lymphoma study group, where patients with primary CNS lymphoma were treated with a very active drug, which is high dose of intravenous methotrexate. And as you can see that if we identify patients that are going to be fit enough to receive this methotrexate-based induction and consolidation, the outcome is going to be quite similar to those that we find in younger cohorts. So again, the assessment of geriatric impairments are needed in order to identify which patients are going to be benefit from a very active regimen like a methotrexate-based chemotherapy for primary CNS lymphoma. And if we want to improve not only the survival, but also the quality of life, we have to learn not only to prescribe drugs, not only to prescribe chemotherapy to our all the patients with hematological malignancies, in this case lymphoma, but we have to start learning to prescribe exercise. And in this very interesting study, the prescription of exercise training in adult and elderly patients with lymphoma that are going to be treated with chemotherapy. You can see that in the intervention group, after the exercise training, we are going to find an increase in the physical functioning, emotional functioning, cognitive function, and we are going to see a reduction in symptoms like fatigue, nausea, vomiting, pain, and dyspnea, and we are going to improve the appetite loss and constipation. And the few words for Hodgkin lymphoma patients, we are trying to make a great effort in order to identify chemo-free regimens for all the adults with Hodgkin lymphoma that they are not going to be able to tolerate the standard ABVD regimen that contains anthracycline and bleomycin, where toxicity is much higher than in younger patients. And in this study published this year, this attempt of a chemo-free regimen of brentuximab vedotin in combination with nivolumab, an anti-PD-1 monoclonal antibody, was explored in all the patients that were going to be ineligible to receive chemotherapy for their Hodgkin lymphoma. But unfortunately, this trial was closed early after the interim analysis because this trial failed to meet the predefined criteria. So these are the most relevant highlights in the field of lymphoma, and hopefully we can meet you all not only in the OncoAlert but also in the Twitter sphere, and you can follow the account of OncoAlert and also mine in order to be updated with lymphoma news and also geriatric hematology and geriatric oncology news. Thank you very much for your attention.
Hi, my name is Rolfo. I'm the Director of Thoracic Oncology and Early Clinical Trials at Maryland University in Baltimore. And it's a pleasure to be here in this colloquium of OncoAlert. I would like to thank especially Gilberto Morgan and all the team of OncoAlert. And I hope that you can get in this small session some insights about liquid biopsy. That's are my disclosures. Majority of the talk that I will do is focusing on lung cancer, but several of the other informations in other tumors will be also available. One of the first things that we have when we are talking about liquid biopsy is that we need to remember that several of our patients, unfortunately, are arriving to the consultation without a complete molecular profiling, or even with some of the single determinations, specifically in lung cancer, that we know that is important for the decision-making process. So these delays in the acquisition of the molecular profiling of the patients is putting an important problem for clinicians, especially for patients and families, because we delay a lot the treatment. So liquid biopsy can be one of the tools that is giving this solution for patients. When we are talking about liquid biopsy, obviously we are referring to different members of the family. The most common one used in clinical practice, and the one that I will discuss or will focus during this conversation with you, will be the free DNA, but also CTCs, exosomes, platelets, microRNAs, long non-coding RNAs are part of this big family with different properties and different opportunities. In the case of my lab, we are working in exosomes and biomarkers, circulating biomarkers, because we believe that this is an important opportunity for get some biological insights that are possible to catch with exosomes specifically, or extracellular vesicles. Some considerations that we will talk today in this talk is about the coverage, the kind of techniques, the sensitivity, the concordance. So that's our important considerations. Obviously, when we are talking about application, we would like to have a method that is able to go for all the journey of the patient from the very beginning, even from the screening of lung cancer until the mechanism of resistance identification. In the last years, obviously, several of the efforts were done here, and we collected an important, robust data in the advanced disease. So that means the identification of target, specifically drug-able targets. The idea that we are monitoring these patients is something that is relatively new, but it's very important because we are able to catch the clonal evolution and obviously the mechanism of resistance for this TKI. Some of the evidence is also collecting now, and is a very nice area of interest because we are talking about screening of lung cancer in this case, but also in other tumor types, diagnosis and prognosis and prediction when we are talking about minimal residual disease before and after the surgery. The possibility to catch some signature for adjuvant treatment is also very important. Some of the considerations that we need to do when we are talking about liquid biopsy, obviously, is passing about the fraction for an allelic variant, and that is important because this is the percentage of DNA that is present in the sample, and it could be variable between 0 to 90%. It depends also of the histology, but also is very variable between the histologies and different patients. We have patients that are not shedders, that is something that we need to take in consideration as well. But also in patients who have minimal tumoral burden could be more difficult to catch and a good quantity of DNA. So these kind of considerations are important. We will come back to the BAF in a second time. This is the same that I was discussing right now. So different tumor types, different variability, but also you see variability inside the same tumor type from different patients. So some advantage from the blood, obviously, is that it's a less invasive, it's simple to obtain. We can have a more possibility to repeat the samples during the journey of the patient treatment. And also that's important because we are able to do the monitoring, but also we can catch some genomic alterations in the heterogeneity that is not possible to have with the tissue. Tissue, for the other side, is a gold standard of care, obviously, but have some possibilities also to help us when we have patients, like I said before, non-shedders, or we have some negative results. We need to confirm in some cases with tissue biopsies. Some limitations of the liquid biopsy, that some negative results, like I just say, need to be confirmed by tissue biopsies. And from the side of the tissue biopsy, the lack of possibility to catch this heterogeneity and the limited resource of the material could be one of the problems. In the advantage and of the limitations and the limitations that we have from the technologies, we was starting the history of this liquid biopsy when with the first method that we was using was the Sanger sequencing. That was a very primitive, we would say nowadays, method, but was possible at that time to give some knowledge about the liquid biopsy. Nowadays, we was arriving to optimize high throughput or next generation sequencing, that we are able to do an important number of genes in the panels with a very good coverage and a deeper coverage for sensitivity. One of the problems that we have, obviously, when we are going down with the sensitivity is the possibility of catch some mutational noise that is coming from clonal hematopoiesis. I will back to this topic later on. Important to remember that some areas in the world are using still single determination, single target determination, and for that we are using, for example, digital droplet PCR or beaming that are very, very sensitive, but the only problem obviously is that we cannot do panels. And we know nowadays that commutations are playing an important role in the prognostic of different tumor types. In terms of the false positive and false negative could be the limitation of the techniques, and the false positive could lie in the contamination of the white blood cells, or in that area we are talking about clonal hematopoiesis. Important also that some patients who have different samples from the tissue and the plasma more than 6 months can have, due to the heterogeneity of the tumor, some differences. In the case of the clonal hematopoiesis, that are mutations coming from non-cancer cells, that could be the PBMC, for example. These cells could be containing some mutations, like, for example, KRAS of TP53. The most common ones are the first one that you see here in this graphic, JAK2, T2. This is not only a confounding factor for the results, for when we have the interpretation of the results, but also we need to consider that some of these patients, in a very small proportion, can develop an myelodysplastic syndrome. So it's important when we have some of the mutations identify that we have a molecular tumor board that we can discuss this kind of alterations. The problem with KRAS was not really a problem until now, because now it's not only a predicted biomarker, but a prognostic biomarker, but also a predicted biomarker in the case of lung cancer. The tumor heterogeneity, I say that this is one of the most important contribution of the liquid biopsy. This is the case of a colorectal cancer, and you see in different tissues biopsies of the same patients in different locations, the molecular profile could be different. So with liquid biopsy, we are able to catch this mechanism of resistance, in this case, different. So which kind of patients could benefit from liquid biopsy? Patients who traditionally have an inaccessible or impractical biopsy, and that is one of the common problems. Patients with who traditional biopsy is insufficient, the quantity is insufficient, and we don't have more tissue or is exhausted for complete panels that we want to have. Patients who have disease progression or relapse target therapy, and it's important to consider to detect mutations for secondary mutations, and also consider options for including clinical trials. In the last ESMO Precision Medicine Working Group recommended in the next generation sequencing that was more applicable for solid tumors, but we can translate that to liquid biopsy, multi-gen next generation sequencing for several tumors. So we are now in the concept of tumor agnostic that also could include colorectal cancer and GI cancers in the case of NTRK fusions, for example. The idea to consider also TMB was discussed for this panel of experts, and you see here some of the tumor. We can, obviously, this is a very dynamic field. Some of the things are coming moving very quickly, and we need to be updated on that. It's true that the liquid biopsy was entering in different guidelines and recommendations, starting from the ASCO guidelines in 2017, going to the American Molecular Pathologist, clinical, the ILCC, the CAP Society, and finally NCC guidelines. In the case of NCC guidelines in lung cancer specifically, we have different biomarkers that are corresponding with an important possibility to be treated with different drugs. In some cases, in the case of EGFR or ALK, we have first, second, and third generation of inhibitors. So it's important that we select these patients is in the very beginning of the treatment decision making process. We described in 2018 and the statement paper of the ILCC for patients with advanced disease. We say at that moment go for biopsy, tissue biopsy, and in case that the tissue biopsy is not sufficient, we can go for liquid biopsy. I say right now, some minutes ago, that this is a very dynamic field. So we are now in the process to have a second manuscript for this, because we would like to go for blood first, or at least concomitant with tissue, because there are several robust data there. I will show you in a few minutes. Patients who progress or have, in the case of lung cancer treatment, with TKI and are progressing, we go directly from there to liquid biopsy because it's very easy. And nowadays we can add also from there the possibility to monitoring these patients during the treatment. The NILE study in lung cancer was one of the studies who demonstrate not only that the impossibility to do in some cases complete next generation sequencing with tissue because limited of the sample was not adequate, but also the possibility that catch the 8 guidelines recommended biomarker in 27.3% compared with 21.3% in tissue, and also the high sensitivity and the concordance that was around 98.2 or 100% of predicted positive value for some biomarkers. Obviously, the reduction of in time to have these the results, and finally that the addition of free DNA is increasing the detection by 48%. So the idea to go for blood first or at least complementary is something that is very attractive. Another study that was given an important robustness in this field is the BFAS study. This is a very elegant trial that is including patients with advanced disease stage 3B or 4 with liquid biopsy as the only source for biomarker. And in the data that we know for the moment, at the moment is the ALK arm. And here, compared with the ALEX trial, that is the historical trial with tissue, the overall response rate was 71.7%. You see here that the overall response rate in these patients treated with alectinib by the detection of ALK rearrangements in blood, you see that it's very high and it's very concordant what we have in the tissue. Another trials like the VISION, that is the phase 2 trial with the tepotinib, and that is for MET-exon 14 skipping mutation. This trial is very interesting in my point of view, because we have the data of the liquid and the tissue biopsy, and you see that the concordance here is very similar, is very high. So we have a good opportunity to catch also some of the new mutations that we are looking for these patients. Some years ago, Charu Agarwal with the group of Pennsylvania showed this real world data that I think are very interesting, because we have here in this waterfall flow an important positive results from some of the biomarkers, different biomarkers here. And when we translate that in the allelic fraction variation and the RECIST, you see that the majority of the patients have a very low BAF compared with the others ones. So what is the message of this slide? So when you see in your report a target, a driver that is there present, the allelic fraction is not really important. It's important that is there, the presence, and can respond to these treatments. The timing to the sample draw is very important. Obviously, I say before, important number of tumoral burden is more positive or more possible that you will catch a better quantity of DNA. When the patient is responding, obviously you will not have this opportunity, but you can catch even though the dynamic evolution in some cases. Some interventions, like for example, radiotherapy, can give an increase of the DNA. Obviously, this DNA is not coming only from tumoral cells, so because you're producing more apoptosis and more lysis, so this is could be a confounding factor as well. In terms of the kinetics of this BAF, so the idea that we can have a kind of increase or decrease or even clearance, that is very important, and it's applicable for EGFR, but also is applicable in immunotherapy, that we will go there in some slides more. I say that the possibility to catch intratumor and intrapatient heterogeneity is one of the major contributions of liquid biopsy. And here, in the monitoring of the patients, we can have different scenarios, like mutations that are coming from de novo. That's the case of, for example, a patient treated with osimertinib and have mutations like it's 797S, that is a new mutation, or resistant that emerges from pre-existing mutations, and that is the case when we have some co-mutations, for example, MET exon for MET amplification, for example, or co-alterations, MET amplification and EGFR, and one is leading at different moment the process of progression. So it's important that we discover and we detect which kind of mutation is in order that we are tailoring the treatment properly. In other tumor types, the new data that we have, for example, in the Triton-2 study, that is rucaparib in patients with prostate cancer, with BRC1 and BRC2 alterations, obviously important confirmatory analysis with response when we are using rucaparib, and that was detected also by liquid biopsy. The SOLAR one, that is the phase 3 trial with alpelisib in hormone positive HER2 negative breast cancer with PI3 kinase mutations. You see also by liquid biopsy the alteration was detected and the opportunity to have a response was very similar than tissue. Finally, the Beacon phase 3 trial, that is encorafenib, binimetinib, and cetuximab in the case of this triplet, in the case of BRAF's B600 mutations in colorectal cancer. You see also that positive data in free DNA were in the concordance in the tissue and the liquid biopsy around 85.5%. So the liquid biopsy is going to different tumor types, and actually in August of this year, FDA approved Garden 360 and Foundation One liquid as a platform for liquid biopsy, specifically in non-small cell lung cancer. And in the case of Foundation was also approved for the prostate cancer for the BRC1 and BRC2. There are two novel FDA approved indications that was coming in October and finally in November. One is the mutations for ovarian carcinoma, BRC1 and BRC2, eligible for treatment for rucaparib as a companion diagnostic, and ALK also for alectinib in the case of non-small cell lung cancer for treatment with alectinib indeed. And finally, the mutations with PI3 kinase for breast cancer treated with alpelisib. In November also, the BRC1, BRC2, and ATM genes mutations in patients with prostate cancer were eligible for olaparib was also approved. So very good news in the target area. We are moving a scenario and we are going to immunotherapy. And in this case, in immunotherapy, we would like to have or replicate the great experience that we have with target therapies. And we would like to have some tools for detection of minimal residual disease to tailor in the adjuvant immunocheckpoints, early detection of relapse for initiating the first line immunocheckpoints in low tumoral burden, early monitoring of the response for immunocheckpoints to stop or switch in case of resistant cancers, and also the opportunity to detect secondary mechanisms of resistance and start new target therapies or new therapies targeting other resistant subclones and with another kind of immunotherapy. Unfortunately, this is not so easy. We are talking about a microenvironment. So different things were done here. Obviously, PD-L1 is very poor as a biomarker. It's very weak. We have an important heterogeneity intra-tumor and intra-patient as well. And there is no correlation with another of the biomarker in tissue, that is the tumor mutational burden. Microsatellite instability also is not talking about the same population. So we are talking to three different populations here. In the case of MSI, we can also catch that from liquid biopsy, and we know that there are some trials, like in the case of pembrolizumab with MSI, that have an objective response that is more than 50% in different tumor types. So it's important that we catch this. One of the tools that we have for immunotherapy is the dynamics of free DNA. I was talking that before, and the increase or decrease of the BAF is a surrogate of outcome for these patients treated with immunocheckpoints inhibitors. You have here some examples from lung cancer with impact in the overall survival and progression-free survival. And finally, we arrive to the, I would say this is one of the stars, or was one of the stars in immunotherapy. We don't have clear the role that we have for TMB. Some of the experts say that this is dead, or TMB is already dead, but I think we have still an opportunity to have a Lazarus effect here. Obviously, if you see this timeline, you became shocked because there are several trials, not only in lung cancer, that are trying to incorporate TMB in the trial design, or even other retrospective analysis. So it's not really clear, the data, because we have, for example, in lung cancer, one of the trials that was the phase 3 trial, OAC, using one of the platform, Foundation One, 394 genes with a cutoff of blood TMB of 16 mutations per megabase. And you see that there is patients who have more than 16 mutations per megabase. They have an important impact in progression-free survival compared with the others who have a lower blood TMB. Another trial using another platform, that is the Garden Omni, is not still in the market, 500 genes, cutoff of 20 mutations per megabase, also impacting the progression-free survival. So the data are positive for progression-free survival and also overall survival, but you see different platform, different number of genes, different cutoff. So we don't have still clear here ideas what is happening. So one of the trials that is coming to clarify that, and I showed this slide before, is the BFAST. And in the case of this arm, the blood TMB, that will randomize patients in atezolizumab versus platinum-based chemotherapy. You see that here we will have some of the answer, because this is a prospective study and will be very clarified, give several clarifications for this specific topic. Some concerns that we have with the use of TMB, obviously, like I said before, no correlation of the PD-L1 status, lack of the standardizations across the different platforms and cutoff. Some of the experts say that it's already dead, but I think we need to have some more information, not just a number. We need to be a little bit more academic if we want to have this Lazarus effect, no pushed by the industry, to give an opportunity of one biomarker if we want to really success, and obviously have a better trial design. So in my opinion, it's not still dead if we give the opportunity to demonstrate that the important thing in the blood TMB or in the TMB by tissue is that the quality of the mutations that are able to present or introduce neoantigens and that is the mother of all the immune process. What is the new frontier for liquid biopsy? Have some methods that are able to identify lung cancer screening or lung cancer in the early stage, or even for colorectal cancer or minimal residual disease as well. Colorectal cancer is one of the areas that is more advanced in that sense. In the case of the screening or early lung cancer detection, the only method that we have right now is the low-dose CT scan screening, but there are some methods, some approach like the methylation or the plasma leukocyte free DNA analysis that are combining different technologies and machine learning approach to give an answer for this patient. So this is an important topic, because here we are able to save a lot of life if we are putting some addition to the low-dose CT scan screening. In the minimal residual disease, we would like to have some signature test that is giving us an idea what we need to do in the after the surgery, which kind of adjuvant therapy we need to give to the patients according to the molecular profiling, but also to catch the patients that are relapsing in different waves and at different times. So this is important, and this is the object of different studies. Like you have here, this is the early detection or minimal residual disease with different platforms, different sensitivities according to the different stage, but also different methods of enrichment technology. One of the studies who will give several answers for that is the Mermaid. There are several of the studies. This is one of the example. And I think the design is very elegant, having after the adjuvant therapy, this minimal residual disease, positive or negative, and randomizing the patients to receive treatment according to that. The last frontier for liquid biopsy could be the cancer interception or even the metastasis interception, that are all the mechanisms that are we are able to catch before the cancer start to grow in the body of the patients. So it's important that we are looking for that. Several years we was investing here in stage 4, but it's time that we move in the other direction in order to catch the patients before, because that represents several lives that will be saved, and also a decrease also of the economical impact in healthcare. So my home message for liquid biopsy today is to obviously we need to be conscious about all the economical, socio-economical challenge that we have in the different regions in the world. We are talking about liquid biopsy, and it's not the same having 2 FDA approved methods and still don't have even a next generation sequencing in different areas of the world. So this is something that we need to recognize. Important biological and technical aspect. We prefer, in this case, next generation sequencing as a platform. We would like to see the application of liquid biopsy across different tumors. Lung cancer was the first scenario and give a lot of insights, but we have nowadays also data in breast, in prostate, and also in pan-tumor applications or in agnostic tissue applications. The exact knowledge of the limitations that we have from different techniques is very important, because also it's also important the pre-analytical conditions. It's also important the post-analytical, that means the interpretation of the results. The idea to go for the blood first in some tumors is very important, and it's very close in terms of time. And obviously in immunotherapy, we are in the beginning of a very interesting journey that we will have several news in the near future. I would like to invite you to different meetings that were already passed, but you have still the material available for some months. This is the ILCC liquid biopsy hot topic, and the ILCLB, the International Society of Liquid Biopsy, that we have for free the data there for the material there for 3 months. Here you have my email and my Twitter. I'm happy to be in contact with you. Thank you very much for your attention.
Thank you all for joining us today. Don't forget to join tomorrow for day 5 of the Best of 2020 in GU Tumors, OncoAlert social media, and FDA approvals, with great presenters like the heart and soul of the network, Dr. Tony Schwery, Dr. Andrea Polo, Dr. Neeraj Agarwal, Dr. Sean McBride, and myself, Dr. Gil Morgan. Remember that regardless of geography, we're all OncoAlert.